Okay. So echoing Zara and Stephanie, I also want to welcome you and thank you for making the time today to come along to this session. It's really a pleasure for me to be here to talk to you about patient engagement methods and how we're going to approach it ultimately in the CAR-T work that we're involved in that Manoj is going to talk about later. So what I first want to talk about is some top tips and best practices in patient engagement methods, and I suspect that some of this will be preaching to the choir to some extent, but hopefully there will also be some new insights that you may not have thought of as we go through this. So I'm Justin Presseau. I'm a scientist at the Ottawa Hospital Research Institute, assistant prof at the University of Ottawa, and I'm also the scientific lead for knowledge translation at the Ottawa Methods Centre. A little bit more about me. So this is meant to represent that I kind of feel like a fish out of water a little bit here. I spend a lot of my time in that sort of second valley that Zara represented. So I'm mainly focusing a lot of my research time and consultation time on support. Once we have the clinical trials in, we have the evidence, we have reviews of that evidence, we have guidelines guiding healthcare professionals and patients and citizens on how to adopt that evidence. How do we support them to do that? So working with patients, working with citizens, working with healthcare professionals. But increasingly, turning my eyes towards, and us as a group towards the first valley and understanding how we can take some of those knowledge translation approaches and start even earlier on in that first valley so that we're thinking about patient-related and citizen-related issues from the start, as well as considering the role of healthcare professionals through that, who ultimately have to integrate that into routine care. So trying to get at that 50%, 25% issue earlier on in the process. So what I'm hoping to cover is quickly on how we might go about involving patients in research. And again, I'm using patients as that kind of generic term, but substitute that for, I actually prefer partners as what I typically use, but I substitute for patients for this talk inappropriately, clearly. So we'll talk about how, we'll talk about who we might want to involve and how to find them. And then going back to what the exercise that you just had, thinking about ways that patients can be involved in the different phases that we identified. And then I'll point to some additional resources. Before going forward, I just wanted to highlight, and a lot of my examples come from a sort of UK perspective. I spent 10 years in the UK and moved back last year. So a lot of my experience has been from the UK and the involved perspective, so that'll sort of run through a lot of this talk. But I wanted to highlight what Dame Sally Davies, who's the chief medical officer, in other words, the sort of the top doctor in the UK, once said, or was quoted as saying, no matter how complicated the research or how brilliant the researcher, patients and the public always offer unique and valuable insights. Their advice when designing, implementing, and evaluating research invariably makes studies more effective, more credible, and often more cost efficient as well. So I think that resonates really with me, and I like to be able to quote that and stand on definitely her shoulders. So I wanted to build on what Zara introduced and try to get you to start to think about how have you yourself been involved as a patient in research, if you have been, or if you're a researcher if you have a researcher hat on, in what ways have you involved patients in your research, just to get a sense of your experience both on either side or both sides if possible. So have a think about it, speak to the people at your table or your neighbor, and then I'll quickly go around the room in 5 minutes' time. I wanted to give you a sense of my own experience. So I've done this a few times for a few projects, but this one sort of stands out for me. So when I was in the northeast of England, I led a cluster randomized trial trying to support primary care doctors and nurses effectively to do better by their patients with diabetes. In other words, trying to implement guidelines that suggest that they provide certain types of advice, prescribe in certain ways, and examine feet in certain ways. We previously showed that that wasn't quite happening in an optimal way. So we designed an intervention, delivered it randomly to a set of practices, and then evaluated whether it was effective. So it involved working with health professionals, but also working with ultimately people with diabetes as well. So in order to make sure that we were understanding patient perspectives throughout, we first involved Margaret Hunter, who happened to have been given an MBE by the Queen, of all things. So it was fantastic to involve someone of that caliber on our team. And so she had the experience of having diabetes since the 70s. She was involved in the grant application process itself. She was a named co-investigator on our grant and treated at the same level as all the other co-investigators. She commented and is a co-author on the published protocol for the trial, and really provided comments and views on project materials and plan processes throughout. She attended all team meetings, initially on her own, then increasingly with her husband, which was fantastic, and our research associate also went to visit her at home to discuss materials over tea, which was great. She also, and we had regular contact with her throughout the process. And one thing that really struck me in going through this is that, certainly as a researcher, primarily with a researcher hat on, I tend to get caught up in the methods to make sure that I'm doing the most robust science that I can. But involving Margaret in particular in this project, always, and particularly at the team meetings, reminded me of why we do this research in the first place. And I think for me as a researcher, that is essential to not get bogged down by the research process. But it also highlights that, particularly within diabetes, but also I suspect within the types of trials that we'll be talking about later, life happens. And so with the context, and unfortunately Margaret passed away 2 years ago during the process of the trial, but that just, which is clearly unfortunate and really sad, but also highlights that it's not a reason not to involve people, that if they're becoming ill, that there's ways to appropriately involve people if they can, all the way through to end of life, because they can still make a contribution if they want to. So that was Margaret specifically, but we also involved a patient group, support group that was led by Diabetes UK, which is a funder in the UK. So this is a local group that meets on their own voluntarily at a local church hall to talk about diabetes and provide support to each other. But they also invite researchers to come along so that they can provide feedback. So we had yearly group discussions with this team, and some participants were super keen on our project, so they also were happy for us to visit them again at a convenient place, usually at their house, to provide additional insight into the materials that we had and the ideas that we had for the intervention itself. So not to say that this is by any means the way to do it, but I just wanted to give you an insight into sort of my perspective and how I've approached this so far. But clearly within this room, you guys are experts in participating as well. And so one of the reasons for having that discussion earlier was just to highlight that we can learn from each other in this process. So the next few slides are really just tips for how to involve patients and partners in your research. So like I say, I suspect some of this will be preaching to the choir, but what I find is often when you get into the heat of conducting research, these things can fall by the wayside unless you have it close to hand and making sure that you're reminding yourself that it's important to do all these things alongside all the busy things that you need to do for the research itself. So first, involve people as early as possible, even as early as identifying, prioritizing the research questions themselves. You don't need ethics approval to do that, particularly if they're partners in the research. Sometimes that's a misconception. And integrate people as key members of the research team. Make sure to build in resources, whether it's funding resources or materials, to allow that engagement to happen. Offer training and support to your team, not only from the perspective of patients and partners, and there is training that Zara and others provide for that, but also for the research team as well. Often researchers are relatively new to involving partners and patients in the research, and so there's a need for training on both sides. And if you can build that into your process, it'll make for a smoother process. I find, in my experience, naming someone as a lead for patient engagement within the team as a key point of contact just makes it more straightforward, I think, from the patient's perspective, because research teams can be large, and what you don't want is everyone emailing the partner at the same time asking conflicting questions. So streamlining it through one key person that has ideally experience in the role and is resourced to do that, so has the time and is part of their job. Ideally that works well. Which fits into being accessible, allowing yourself the time to be able to engage. And also allow the time to build for meaningful relationships. It sounds obvious, and it goes back to Zara's point about tokenism. It's really, when it gets to the point from a research perspective of putting a grant together, and sometimes we really want to have a patient engaged, but we haven't spoken to anyone ahead of time. That for me is already starting to get into tokenism, and we need to start to build meaningful relationships early, and this is why having a room like this and other rooms like it allows for relationships to start to foster, because ultimately I think it's about patients and partners and citizens becoming part of research teams rather than being dropped in. It's also clearly important to be clear with what you're expecting from a research perspective. Be clear with people that you want to involve in terms of the steps of the research and the timelines, any opportunities there are for involvement, and importantly, make it clear that people can stop at any time without any repercussions. So this speaks to whether people get busy, other competing demands, or even if there are illness concerns. Reassure people that it's not that signing up for a 3-year project that's funded, a project that's funded for 3 years or 5 years means that you need to be a partner for that whole time. You can be, but it doesn't need to be that way. Provide additional support if topics are sensitive, which makes sense, and talk about what happens if people become ill for periods of the research, and speak openly about that from the start. Again, just treating people as humans, I think, is the motto here. And after the research is completed, also think about or plan in advance for how you will involve your patient, how patient partners can be involved at the end of the project and beyond, to support them in getting involved in other projects, organizations, and groups, because there'll be a set of experiences and expertise developed by participating in the research process that may springboard someone on to the next project that they might want to be involved with. And facilitating that, I think, thinking through how you can facilitate that is important. Oh, sorry.
In addition to your key tips and feedback, there should always be something built in as feedback on that.
Absolutely. Absolutely. Yeah, I'll get to that as well. But yeah, constant feedback and communication, I think, is key.
Well, after it's over, because
I see what you mean.
It's publications or it's gone into practice or whatever it's come out of it, because that helps validate your involvement.
Absolutely. No, that's fantastic. Thank you for that. So I wanted to make a few points specifically about meetings, because often that's one of the venues in which patients and partners tend to be engaged most often with research teams. Not the only one, but an important one. So I want to talk about issues around before, after, and the cutoff, or the during and after is cutoff there. So before, I think for me, it's really important to sort of set the stage, and as a researcher and a research team, to meet with patient partners before the first team meeting, to start to further establish that relationship. What you don't want, and you may have experienced this yourself, is the first meeting, or the patient and the partner's first meeting with the research team to be the first research meeting. I think that is putting someone into the deep end, and I don't think it's fair to do that. And so often we try to, we meet with people ahead of time, ideally at a place that's in their own setting, or at least over the phone, just to set the stage, and recognizing that they may be new to this whole process. Think about when you do conduct meetings that they're easy to attend. Consider things like Zara mentioned around childcare, parking, paying for parking, considering that people might have to take time off work, might have to take public transport, all these things, and that goes back to building in the resources to be able to do that effectively from the start. Tends to be that mid-morning and early PM is usually easiest, but obviously that'll depend on the people that are involved. Accessibility issues, dietary requirements, practical matters around visual, hearing impairments, interpreters and translators. Sounds obvious, but making sure you operationalize that effectively is really important. And that often comes back to the chair, which brings me to the during part. Depending on how the meetings are organized, often you have a chair or a rolling chair, making sure that that chair welcomes everyone from the start, make sure that everyone is introduced, which again sounds straightforward, but you may have had the experience where meetings just sort of start and there's an expectation that people know each other and things get going. I certainly have had that experience. And so I think making sure the chair can chair effectively by preparing them is important. Continue to have pre-meeting chats, so it goes back to that discussion, making sure the discussion, the constant flow of communication to discuss what's going to be spoken about during the meeting, what are the expectations from both sides, from either the research and the contribution that patient partners might want to put in. Make sure everyone has an equal voice. Jargon and acronyms are the bane, I think, of research in general, and particularly really challenging for anyone who's new to the research, whether they're we're thinking about patients and partners, but even if you're a researcher in a new field, getting up to speed with the jargon and the acronyms is a challenge. So obviously it's going to be a challenge for your patient and partners. And remembering that, making sure that things are clear or followed up on later if jargon and acronyms are needed to some extent. Make sure the chair regularly checks understanding as we go on. Make sure there's frequent breaks. So all of these straightforward things, but again, when you're chairing a meeting, you have an hour to speak with people, sometimes these things fall by the wayside. So I find having this fresh to mind can be helpful. Consider the format, often to allowing engagement, particularly in the early phases where people are getting to know one another. Small group discussions work more effectively than sort of one person speaking and then asking for feedback. I think that's an intimidating potential situation unless you're sort of a very confident speaker in general. And sometimes it helps to have a specific, if it's a particularly large project, to have a sort of mentor, buddy person that people can go to speak to during the meeting or afterwards. And then the last cutoff bit is just, this goes back to the point that was made at the back, ask for feedback from your patient partners after the meetings to see how they can be improved for them in the future, to make sure that they're serving the purposes and expectations that they had going in, so they don't feel, so that they are fully integrated, which is the purpose of that meeting. So just one slide on who to involve. Some thoughts again on. We find it's helpful to have more than one person, to have a few different views, but again, taking the time to build those relationships, building in the time to do that. Think about the perspectives that you're hoping to get. So I think there's two ways to think about this. You can involve people that have the actual lived experience as a patient or as a caregiver, which provides one perspective, one important perspective, but there's also groups and organizations and people that represent those groups to provide a sort of collective voice of the patients that they represent. And sometimes those perspectives can be different, sometimes they're complementary, but think about what voice or whether you want both voices at the table when thinking through the research, because they might provide different things. Also think about what level of experience you are interested in or you expect. Some people might have zero research experience, which is fine, but other people may have experience in a lot of other research projects, and thinking about that level of experience when approaching things so that the approach is appropriate given where people are at in their level of experience. And working with one of our patient partners suggests that it can even be helpful to develop a sort of person spec, at least internally, if not to share with partners, to help to think about what you want, who you want to involve in their anticipated role, just so it's clear. Certainly when I start to build relationships with partners to involve in my research, that first question is, well, what do you want from me? What can I contribute? And having an idea of that to begin with, again, it sounds straightforward, but it's sometimes not thought of when we start to try to build these relationships. But the bottom line here is ultimately who you involve depends on the contribution you're hoping that they will make, and that's a two-way street. So this goes back to Zara's phases, though her slide is a lot more colorful and better designed than mine. What I'm hoping to do just for a couple of minutes is for you to think through this research process. Having thought about it already, what the process might involve, now we have a cycle to think through. I just want you to take a couple of minutes with the people at your table to think through where have you involved patients or have you been involved as a patient contributor in any of these levels, and we've talked about that a little bit already, but I want you to think about it a bit more, and in particular, think through, are there opportunities, new opportunities that might not be obvious ones in which patients and partners can be involved, notwithstanding the innovative approaches that people were talking about earlier. So I'll give you 3 or 4 minutes, and then we'll chat. So that's sort of a perspective of the patient as a participant in the research, and I think what you're suggesting is, in a sense, partnering with patients from the start in the research might be able to inform how one might approach if participants were to call up and ask for there might be appropriate ways that patients can suggest as partners in the research rather than participants in this case. Yeah, fantastic.
Looking really closely at what the informed consent says.
That's great. So I thought what I'd do is just highlight a couple of the boxes and again some sort of top tips about or ways in which people could be involved. So if we're talking about the early beginning phase of the research program and just identifying questions and prioritizing them, different ways that people approach this is through holding discussions with existing groups and networks, so that goes back to the point made here. inviting people to an event or a workshop that the research team might design, but often it's helpful to involve someone that's a little bit independent from the researchers themselves, an independent facilitator, so that you avoid the risk of the researchers influencing the agenda too much, and you really allow patients and partners' views to come through that meeting. But also on the flip side, as a researcher, attend meetings held by service users and service user groups or patient groups that are going to be held anyway to get a sense of what they're talking about. We'll talk a little bit about this later, actually using this as an opportunity for more generalizable research and by using surveys, interviews, and focus groups to understand patient perspectives. And ask organizations like BioCanRx or funders who support the public about feedback that they're receiving from people who use services to see what's coming through the pipeline and the perspectives that they're interested in.
Can I just make a couple of comments
Yeah.
on some of the research that we did? Focus groups, that's very popular in the Aboriginal populations. They like to, in fact, one of the research I was mentioning earlier, we actually had one arm that was just for Aboriginal people, and that was all done in circles, because that's the way they wanted to do it rather than individually. So I think that one thing is patients can really help you with is understanding cultural differences in your populations, in your research. And the other thing that became quite interesting was who's asking the questions for you, who's actually administering research. And sometimes patients wanted people from the cultural groups that they belonged to, or even sex that they were, or sexual orientation that they were, whatever. And sometimes they didn't. They were afraid that if they said things in front of people from their own communities, that it would get out to everybody in their community somehow. So that can be an issue.
Absolutely, and it speaks to the point of possibly involving patient partners in actually conducting the focus groups as well, and being the facilitator, or not, exactly, yeah. I don't know if you've heard of this. It's the James Lind Alliance. So this is an organization in the UK that is really devoted to identifying or conducting what they call priority setting partnerships. So working with patient and patient partners to identify and prioritize unanswered questions about effects of treatments in specific conditions. So they have a very specific method that they use in order to do that, involving multiple stakeholder meetings, and to brainstorm and highlight the top 10 sort of unanswered questions that patients feel need to be addressed. And so they produce a number of top 10s, which I'll show you on the next slide, and often can be a really strong component to justify funding if there's an emphasis on this is a research question that you're interested in as a researcher is synonymous with what patients are saying. So here's, you might not be able to read everything here, but what I'll do, so this is just the list currently on their website of the top 10s across a number of conditions. So asthma, autism, prostate cancer, hair loss, sort of runs the gamut. And I just wanted to highlight one, not that you need to read all the top 10 here, or you can even see the top 10. So this is for the process that they did for unanswered questions and priorities for kidney cancer. And I just wanted to flag the patients themselves came up with the number 4 here. Can we develop better therapies that use the immune system to fight cancer? In other words, immunotherapies, which is clearly exactly what we'll be talking about here. So this is clearly a patient priority as much as it is a research priority in itself. So the stars are sort of aligning in that area. But if you're interested in that whole process, I linked to some guidance at the end to talk about that method of the James Lind Alliance. 2 other elements, so involving patients and partners in designing research and developing the proposal itself. So again, this is even before the work starts, the research starts, because you can demonstrate to funders, which is increasingly important. So when I was in the UK, there were actually components of the grant application processes that we actually had to say how we involve patients from the very beginning to identify the research questions. And I suspect that's coming to CIHR and other funders as well. Yes?
And I've been involved, particularly in say with cancer, you not only have to say how you are going to resolve patients, the patients actually vice versa, right?
Yeah. And actually just submitted a paper to a journal that bounced right back to me saying that they now require that there's a paragraph that says exactly how we involve patients from the beginning. So it's built into the paper, to every paper in that journal now. It can also help to identify areas where there might be ethics considerations, and we'll talk about that later as well, so that your patient partners can advise on potential solutions for tricky ethics issues that might trip up ethics committees, but might be fine from a patient perspective or not fine. suggest ways that people can meaningfully be involved in various stages, talk through the recruitment process, make sure it's practical and feasible. It sounds obvious, but researchers like to make assumptions about these sorts of things. And so involving people from the start, help to develop the budget. So it goes back to making sure there are things that are resourced for parking and even honoraria, and helping to develop the written materials so that it's understandable. There's a data collection component. So people might want to be involved in the literature search to get a sense of what do we know from the wider literature. They might want to be involved in supporting recruitment, in developing the research tools, and pilot testing, and actually, like you say, carrying out the interviews and focus groups or not, depending on the preferences. And so starts the line between researcher and patient partner starts to blur when we start to get here, but I think it's something that's worth offering, because if people want to be partners alongside the researchers, they can be researchers as well. There's no reason why they can't be. Which falls right through to analyzing and interpreting data, whether it's interviews and qualitative work to identify themes that researchers might miss because they're just not aware of or not interpreting it in the right way, or checking that the face validity is appropriate, highlighting findings that might be more relevant to the public. And going back to a point made at the back, patients aren't sort of empty vessels that are, and you know this clearly, participating in research. They come with expertise. They have jobs, they have experience, in some areas probably more experience than a lot of people on the research team itself. So offering and having the potential to draw on that expertise, I think, is a real opportunity, one that's often missed in partnering with patients. And then finally, the kind of the more obvious one, but I think still important, the role at the end in terms of dissemination and implementation, whether it's through newsletters, providing access to groups and forums that researchers may not be aware of generally, speaking at conferences, and one that's really important to me as a researcher is making sure at least to acknowledge, if not to offer co-authorships on journal and newsletter articles that are produced from the research to patient partners, because they're contributing at a same level as the research team, so why not be a co-author? So just to finish off, these are the resources, and I'm sure you'll have access to the slides if you want to see them. So that's just Involve, the SPORE strategy, and the James Lind Alliance links for more details. And we'll have time for questions later. So that was a researcher perspective, clearly, but I think probably even more interestingly and more relevant is the same perspective, but from a patient partner.